Hello. In this discussion, we'll be talking about hepatic cirrhosis. So let's first define what cirrhosis is. So when I say hepatic cirrhosis, this refers to a chronic disease wherein the normal liver is replaced by diffuse fibrosis, and the effect of which is that it disrupts the structure and function of the liver. In other words, there is scarring of the liver, and this scarring is what we refer to as fibrosis. This scarred tissue of your liver is not fully functional. There are three types of cirrhosis. So you have the term Laennec cirrhosis, then we have the post-necrotic cirrhosis, and then the other one is biliary cirrhosis. Now, let's talk about your Laennec cirrhosis. Your Laennec cirrhosis is also known as your alcoholic cirrhosis. It's the most common type, wherein the scar tissue surrounds the portal areas. If I talk about the portal areas, this is the area where your portal vein and other prominent blood vessels that passes through the liver can be found. So, a scarring or compression in this area would mean compromise of the cardiovascular system. As the term implies, the cause of this is alcohol consumption. Then we have your post-necrotic cirrhosis. Your post-necrotic cirrhosis is characterized by broad bands of scar tissue. So there's still scarring. But the common cause of this one is your acute viral hepatitis. Then we have your biliary cirrhosis. Your biliary cirrhosis is scarring that occurs in the liver around the bile duct. This is less common, but this is caused by your cholelithiasis obstruction and then your infection, such as your cholangitis. As we might have touched under cholelithiasis, once there is an obstruction in the common bile duct, the tendency is for the bile to be stored in the gallbladder. The tendency is for the gallbladder to dilate and then the ducts to dilate also. One possible thing that may happen is for the bile to go towards the liver. And once the bile proceeds towards the liver, the tendency for autolysis occurs. When I say autolysis, that's the destruction of the cells of the organ secondary to the product also that it's being produced. So if we can recall, bile is actually produced by your liver. But if bile is staying in the liver, it has the possibility to destroy the liver itself. Okay, hence leading to scarring, such as your biliary cirrhosis. So this is a comparison of your healthy liver and then your cirrhotic liver. Notice the smooth edges when we're talking about your healthy liver. But if I'm talking about your cirrhosis, there are presence of nodules and there are presence of irregularities. And these irregularities are your scarred tissues. Okay, so these tissues are not anymore as healthy as it should be. These tissues are not functional as they should be. So this is a comparison again of your normal liver going towards your end-stage liver cirrhosis. If you can notice, okay, the size of the normal liver, okay, is like this one. And then it's a tendency to be inflamed. Okay, there is a slight inflammation when there will be hepatitis. When it comes to chronic hepatitis, there will be a gradual reduction in the size. But later on in your end-stage liver cirrhosis, the size of the liver is smaller. Okay, this is because of the reduced number of normal functioning hepatocytes. And instead of normal functioning hepatocytes, we are seeing fibrous connective tissues, okay, and then fatty deposits along the liver. So this is again your cirrhotic liver. As you can see, there are presence of irregularities and nodules on the surface of the liver. What are the risk factors? For Laennec, of course, it's alcohol. Chemicals, you have your carbon tetrachloride, you have your chlorinated naphthalene, you have your arsenic, and then you have your phosphorus. So if you have encountered or encountering patients who are working in factories which uses these chemicals as raw materials, you need to educate your patient on the proper use of PPEs because this could be a risk factor for cirrhosis. Then you have your infectious schistosomiasis, a parasitic infection. And then it's more common among men, especially those ages among 40 to 60. Why is it ages among 40 to 60? Because the tendency of your risk factors is that for its effect to be cumulative. So when I say cumulative, okay, the effect of your chemical exposure and then your alcohol exposure tends to accumulate in your liver as we go on time. Okay, so this is cumulative. That's why it's usually the middle adult to the old adult which is affected by this kind of disease. So look at this one. This is a CT scan showing a patient who had infectious schistosomiasis. So this is your schistosomiasis. Okay, this is the microscopic view of your schistosomiasis in relation to your liver cells. If we would look at the CT scan images, okay, you will see these white areas here. These are your worms already, okay, which are invading your liver. One capability of your schistosomiasis is to travel through the bloodstream. Okay, its eggs could be possibly traveling through the bloodstream. Hence, it can grow to other organs of our body, such as your lung and your liver. If it will grow in the liver, it will result to scarring of the liver, leading towards your cirrhosis. What are the assessment findings? So at first, there will be liver enlargement. Okay, earlier I said there will be a decrease in size, but let's clarify on that. Initially, there will be liver enlargement. The liver will be firm with sharp edge, and then there will be abdominal pain. Later, okay, as mentioned on the slide, okay, it was end-stage liver disease or liver cirrhosis. So on the late stages, there is decrease in size, and then it tends to be nodular. Again, the decrease in size is brought about by the scarring of the tissues, and it contracts the liver tissue itself. So when you have noticed that there is already a decrease in the size of the liver cirrhosis end stage is suspected. Then we have portal obstruction in the ascites. Your portal obstruction in the ascites is already considered a late manifestation. Recall that we are referring to the portal vein here and the portal circulation. Okay, so when I say portal obstruction, it results to your chronic passive congestion. What do I mean by chronic passive congestion of the organs? Once, class, okay, the portal vein is obstructed, the blood will not be able to pass through the portal vein going towards the systemic area, such as your inferior vena cava. Okay, again, the blood will not be able to pass through the portal vein going towards your inferior vena cava. Hence, venous drainage is becoming improbable. With that, okay, the blood which is supposed to come from the GI tract going towards the heart is being clogged up in the organs, leading towards chronic passive congestion of the organs. With this passive congestion and chronic passive congestion of your organs, varicosities may result, decreased blood flow may result, okay, edema may result. For some of your patients, they may manifest with indigestion. Other than that, there is accumulation of protein-rich fluid in the abdominal cavity. With that protein-rich fluid in the abdominal cavity, the risk for your fluid shifting, third spacing, such as your ascites, increases. What else? The risk for infection and peritonitis. What happens among our patients is that there is absence of intra-abdominal source of infection or abscess. Okay, it's not like any other wherein there's a bacteria involved. Okay, here in this case, usually there is an absence of intra-abdominal source of infection or an abscess. Sometimes it's referred to as your spontaneous bacterial peritonitis. Okay, these patients with liver cirrhosis and peritonitis does not usually manifest the usual signs of your peritonitis. For that reason, paracentesis is recommended. So when I say paracentesis, if you have this patient, for example, with liver cirrhosis, and then there is ascites, there are a lot of fluid accumulation in the abdominal cavity. Okay, when the fluid is being extracted from the abdominal cavity, we refer to that one as paracentesis. During the paracentesis or after the paracentesis, the sample should be sent for bacterial analysis. Okay, because there is a very high risk for peritonitis, which is not manifesting like your board-like rigid abdomen. Okay, for this reason, patients with liver cirrhosis are usually started also in broad-spectrum antibiotics until the result for culture and sensitivity would come in. Okay, this infection or peritonitis is usually attributed to the translocation of the translocation of intestinal flora. Okay, which means that due to the distension, due to the fluid imbalance inside the intestines, there may be a possibility for increased permeability, leading towards these bacteria that supposedly reside inside our intestine, okay, to transfer to the peritoneum, which is supposedly sterile, hence leading to peritonitis. Then we have the term hepatorenal syndrome. Okay, this is something that we need to avoid, something that the medical practitioner would do their best so that the patient would not have. So this is hepatorenal syndrome. It is a form of acute kidney injury. When I say acute kidney injury, meaning there is a sudden deterioration of your kidney functioning, which is unresponsive to administration of fluid and diuretic agents. So usually, when I talk about acute kidney injury, my patient would be responding to diuretics, or my patient will be responding to the fluids being administered. But in hepatorenal syndrome, okay, it's an acute kidney injury that does not respond to your fluids and diuretics. Okay, there is no pathologic changes in the kidney. Upon examination of the kidney, the practitioner will not see any scarring, any abnormal deformity or structural deformity in the kidney. There is no dehydration or not even obstruction of the urinary tract. Okay, but you only have a liver problem and then the kidney problem combined. So you refer to this one as hepatorenal syndrome. Looking at it, okay, and looking at its definition, okay, usually the prognosis of patients with hepatorenal syndrome is already poor. Then we have your gastrointestinal varices. So as I've mentioned, okay, this is related to the congestion of your organ secondary to the obstruction of your portal vein. So what happens? Again, there may be fibrotic changes. And then, due to the fibrotic changes inside your liver, that again leads to the compression of your portal vein. With that compression of your portal vein, collateral blood vessels are more likely to be formed. When I say collateral blood vessels, okay, we have these small blood vessels in our organs which are not usually used for major circulation. But here comes obstruction, here comes fibrosis. So our organs have no other option but to utilize these collateral blood vessels. So these collateral blood vessels are usually your esophagus, stomach, and then your lower rectum. They usually occur in esophagus, stomach, and lower rectum. Okay, how would they manifest? There will be distended abdominal blood vessels. We refer to these distended abdominal blood vessels as your caput medusae. Okay, so this is because of the shunting of the blood from the portal vessels into the blood vessels with lower pressure. Okay, again, there is an obstruction in the portal vein. And because of that obstruction in the portal vein, the tendency is for the blood to pool to other blood vessels. Okay, so as I have mentioned, this commonly occurs in the esophagus. And for that reason, we have emphasized that esophageal varices is one of the common causes of your gastrointestinal bleeding. Another concern that we will have with this patient is that the high pressure that is usually contained supposedly in bigger blood vessels, such as your portal vein, could not be sustained by the smaller blood vessels. So if this high pressure would continue to persist in the esophagus, the stomach, and then the lower rectum, rupture and bleed of these blood vessels is anticipated. So your patient may have hemorrhoids, and then later on the varices hemorrhoids would have frank bleeding. Okay, so that would be detected in your FOBT and then the vital signs changes for your patients. Okay, but as much as possible, we try to decrease this pressure so that we can prevent the bleeding. Because if there will be an overt bleeding for this patient, it will be difficult to manage. Okay, it's managed with a lot of fluids and then possibly an emergency surgery. Then we have edema. So your edema is also considered a late sign of your liver cirrhosis. It's because of the decreased plasma albumin concentration. As we have mentioned earlier, okay, the high protein fluids may be stuck in the peritoneum, in the abdomen. So what happens is that the plasma, okay, the fluids within our blood vessels would have decreased albumin concentration. With this decreased albumin concentration inside our blood vessels, the edema is expected to occur because of the decrease of the osmotic pressure. Remember, osmotic pressure is the pressure that maintains our fluids in the intravascular spaces. Now, with the absence or the decrease of your albumin, there will be no substance to maintain those fluids inside the intravascular space. It's leaking out. It's third spacing. That's why your patient would have edema. Okay, your patient would have anasarca. So your anasarca is generalized edema. Okay? This is also related to increase in aldosterone. What happens? Remember, in fluids and electrolytes, once your aldosterone is on hold, once there is an excess of your aldosterone, what are the next substances that would increase? Aldosterone increases your sodium and water. Okay, sodium and water. Just as a recap. So when I say ADH, antidiuretic hormone, only increases your water. On the other hand, aldosterone increases both your sodium and water. So what if sodium and water is increased? Okay, there will be more edema for your patient. Eating edema for that case. And if sodium increases, what other electrolyte is affected? That will be your potassium. Okay, an excess in your sodium levels would lead to a decrease in your potassium levels. Other than that, vitamin deficiency and anemia occurs, particularly your vitamin adduct, fat-soluble vitamins, and then also your vitamin C. Okay, with this, hemorrhage may possibly happen, which is associated with the decrease of your vitamin K. Okay, remember vitamin K is important for the formation of our clotting factors. Okay, your anemia. Anemia is common because your patient would usually have chronic gastritis, impaired GI function, inadequate dietary intake, and even impaired liver function. So your patient would manifest again with weakness, easy fatigability, okay, pale, decreased hemoglobin. And this anemia is again a contributory effect of your chronic gastritis, impaired GI function, okay, vitamin B12 problem, inadequate dietary intake, and then impaired liver function. Then your patient may also have mental deterioration. It's a chronic problem. So hepatic encephalopathy, hepatic coma may ensue. So if your patient is on hepatic encephalopathy, hepatic coma, okay, we need to reduce the waste products inside the body that needs to be excreted for this to be resolved. And the tendency sometimes is that if your patient had hepatic coma, okay, they would have long-term disabilities. Then their general behavior may also be affected. Cognitive abilities, ability to reason out is affected. Their orientation to time and place is also affected. Okay, they become disoriented, which is classic also in your hepatic encephalopathy. And then there will be a speech problems. Okay, speech patterns are altered because again of the excess waste that is going towards your brain. So the clinical manifestations could be summarized as compensated and decompensated cirrhosis. So as the term implies, compensated. When I say compensated, these are less severe symptoms. Okay, they are vague symptoms. When I talk about decompensated cirrhosis, the term implies decompensated. So meaning there is a failure, okay, to synthesize proteins. Failure to synthesize proteins. Clotting factors. Okay, clotting factors already decreased. And then your patient are already manifesting signs and symptoms of portal hypertension. Okay, so there is failure again to synthesize proteins, edema problem, fluid electrolyte problem. Clotting factors, patient will bleed. Portal hypertension, you have your varices still leading towards bleeding. And then other than that, your portal hypertension may also possibly decrease tissue perfusion to other organs because of poor venous return going towards your inferior vena cava. So the signs and symptoms of your compensated liver cirrhosis, intermittent mild fever, vascular spiders. Your vascular spiders are actually manifestations of distension of your blood vessels. Palmar erythema, okay, the redness in your palm. Unexplained epistaxis, so nosebleed, okay, related to your clotting factors. Then you have your ankle edema, okay, that's dependent edema. Then vague morning indigestion. This vague morning indigestion is usually related to the congestion of your stomach and then your small intestine. Okay, the chronic congestion related to pooling of the blood. Then you have your flatulent dyspepsia, abdominal pain, firm and enlarged liver. Compensated liver cirrhosis class usually occurs on the earlier part. Later on, the decompensated on the last part. Hence, the liver on the compensated liver cirrhosis is still enlarged. Then you have your splenomegaly. Try to connect, okay, your RBC problem with your splenomegaly. Plus, the breakdown of your RBC leads to the release of waste products. and these waste products are being processed in your spleen, leading towards your splenomegaly. Okay? Then you have your decompensated. Patient is already having ascites, jaundice, deep-seated jaundice, weakness related to severe anemia, muscle wasting because the body is already using the energy from the muscles, weight loss, continuous mild fever, even clubbing of the fingers. Okay, the clubbing of the fingers is a sign of chronic decrease in oxygen, okay, chronic hypoxia. So once your patient would face the two thumbs, okay, against each other, and then there is no diamond shaped window between the thumb, okay, between the surfaces of the nails of the thumb, suspect clubbing. Again, chronic hypoxia. Then purpura. Purpura is due to decreased platelet count. Spontaneous bruising. Remember, we have clotting factors problem. Epistaxis. Hypotension, because your patient may be bleeding already. Sparse body hair due to lack of protein, due also to poor blood supply going towards the periphery. And then white nails, and then gonadal atrophy. So these are signs of your decompensated liver failure. In other words, other organs of the body could not anymore compensate to the needs of the liver, okay, or to excrete the waste products of your liver. The discussion will be continued on the succeeding video. Thank you very much for your kind attention.